As a first guest lecture, to deliver this first guest lecture, I invite my good friend Dr. Kale. He is head of the department at All India Institute of Medical Sciences, New Delhi, and he would be talking on multi-level discectomy and fusion versus corpectomy and fusion for cervical degenerative disc disease. So it's a debatable topic, and I think Dr. Kale would be able to clear many of the doubts. So, Dr. Kale, please.
Good morning, everybody. First, let me thank the organizers of this meeting to give me this opportunity to present this interesting topic. Thank you to the team in Bhubaneswar and to the team in Mumbai for making this lively program. This is the first time I'm recording it and then sending it, and this will be played while I'll be joining live. So please excuse me if there is a little bit of confusion in this. However, let us begin. We don't have much time. So the topic for today is multi-level discectomy versus corpectomy for a multi-level cervical spondylotic myelopathy. So we know the basics about cervical spondylotic myelopathy. Typically, it's a middle-aged problem, more than 50 years of age. And it's one of the commonest causes. In fact, it is the commonest causes of myelopathy in adults. And many times, in fact, commonly it is multi-level. And we all know there is no doubt that there is robust evidence to suggest that surgical decompression is safe. It halts the progression of deficits. It improves functional status and quality of life. And in fact, it is the standard of care for patients with moderate or severe myelopathy-related functional impairment. Now, the various surgical approaches can be, as we all know, anterior or posterior. There are some approaches anteriorly, discectomy, corpectomy, or a hybrid procedure. And posteriorly, you can have laminoplasty or laminectomy and fusion. Now, the choice of surgical approach is guided by the pathology or the anatomy, in the sense that suppose there is kyphosis of the cervical spine before surgery, then it is better to approach anteriorly, because to correct the kyphosis, you need to go anteriorly, etc., etc. So basically, the anterior approaches are chosen to restore cervical lordosis. Now, I'm going to compare these two procedures, anterior approach. One is multi-level discectomy and fusions, and the second is corpectomy and fusion. And the points I will be considering to decide the surgical approaches are these four: blood loss, the rate of pseudoarthrosis, the hospital stay, and what happens to the cervical lordosis at the end of the period of observation. Now, blood loss, it is definitely more with corpectomy than with the discectomy and fusion. The clinical significance of this increased blood loss in corpectomy is questionable, because the amount of additional blood loss is relatively small. In the hands of a good surgeon, it may be very less, or in some case, it may be very less. But usually people report that it's usually not more than 250 ml. And most of the times, this loss does not warrant any blood transfusion. So this amount of blood loss in corpectomy doesn't actually materially change the management in the post-op period. What about the lordosis? Now, the kyphosis following surgery correlates with greater neurological disability and pain. And the patients who obtain lordosis after surgery, they have better functional outcomes. Normal lordosis should be restored when possible, and it is more so in patients who underwent anterior cervical discectomy and fusion versus corpectomy and fusion. Distraction at multiple points during discectomy and fusion allows more effective curvature correction. Now, that's a very simple physics kind of a point to understand, that if you're doing a 3-level ACDF, you have 3 areas of distraction. And in a corpectomy, you have 1 area of distraction. So the correction, what we get eventually, is greater in the discectomy and fusion series. Hospital stay. So It represents time to recovery. It's usually longer with Copectomy than with the Dystectomy. And the longer hospital stays can have important clinical implications. They can increase the cost of medical care, and it increases with each level. What I mean is, two level is more than one level, 3 level is more, but at 2 and 3, 2 level ACCF is associated with longer hospital stays than is a 3 level ACDF. So every level of corpectomy added increases, and corpectomy itself more hospital stay than discectomy. The pseudoarthrosis. Now, older reports show that low fusion rates associated with multi-level ACDF, 48%, and there are a greater number of graft-host interfaces. However, recent studies, they show that there is no significant difference in the pseudoarthrosis rates, and the increased incidence of pseudoarthrosis is no longer seems to be the case in recent studies. And there are some studies to suggest that a 3-level ACDF may actually offer higher rates of fusion than a 2-level corpectomy, 100% versus 85% to 90% respectively. Now, this article was published in 2012. So the multi-level cervical discectomy and fusion has these proposed advantages. There is adequate decompression of the spinal cord and segmental fixation. There's minimal blood loss. There is low risk of graft complication, and it can effectively restore the lordosis in the patient. While the disadvantages are the risk of non-union, especially, excuse me, according to the old reports, even with an anterior plate added on, it's still, the older reports say that the risk of non-union is quite high. 2.9% in 1 level, 5.4% in 2 level, and up to 17.5% in a 3-level ACDF. And this may be due to the increased number of graft-host interfaces. I mean, every disc space has a graft, so increased number of graft and host interfaces, and therefore the increased risk of pseudoarthrosis. Now, corpectomy, the proposed advantages are that allows a more complete decompression. So the decompression is better because you can reach areas behind the body which may be the cause of compression. Reduce the graft-host interfaces, delivers greater fusion potential, and higher risk of instrument-related complications and graft migration, definitely. But this is no longer, as the technology increases, the surgeon skill increases, this complication goes down. The disadvantages of corpectomy and fusion, the graft failure risk is definitely higher. You have a big cage, you have a plate, so bigger the cage, the more the risk of graft failure. More operation time, more blood loss, and it is inferior to ACDF in terms of segmental angle improvement and the C2 to C7 angle improvement. Now, all this is documented, published literature. There is another concept called a hybrid corpectomy dystectomy. That is, you do a 1-level corpectomy and the adjacent level you do a dystectomy. So you preserve a vertebral body intact within the area of decompression. So this may leverage the strengths of both techniques. You know, you have a disc graft in the disc space, and then you have a corpectomy and a bigger graft or a cage in the bigger space. Or you can do the preservation in the middle vertebral body. Increases the inherent mechanical stability and allows segmental plate fixation. So hybrid also has lesser chances of graft dislodgement. There is greater mechanical stability than the end construct fixation in the multi-level adjacent corpectomies. Let us see at some publications. Here is a paper published recently in 2021. That is a biomechanical analysis of 4 anterior cervical techniques to treating multi-level cervical spondylotic myelopathy, and they did a finite element study. That is, the computer does most of the follow-up. I mean, what happens to the case is all simulated on a computer model. And this Lee and al. In this paper say that ACDF has the least impact on the biomechanics. Theoretically, it could reduce the incidence of adjacent segment. And the stress at the titanium plate or screw interface is the highest in the corpectomy group and the lowest in the hybrid group. So it indicates the highest risk of titanium plate screw loosening, displacement, and fracture after a corpectomy. Another paper published in 2015, a little older, it compared 2-level corpectomy versus 3-level ACDF for multi-level CSM. And these are the numbers. But as you can see, the complication rate is definitely higher in ACCF as compared to ACDF. The mean length of stay is higher. Mortality is okay. The supplemental PSF, that is the number of patients, is higher in ACCF. The mean PSF levels is higher in ACCF. So some parameters which they studied definitely higher in the corpectomy group. The Cobb angle higher in ACDF, the correction of the Cobb angle higher in ACDF, length of follow-up or roughly the same or a little bit more for corpectomy. You follow them probably more carefully. So overall, you see that the ACDF, the 28 patients under the ACDF column show better numbers than the corpectomy group. Now, Mummaneni et al. Compared such groups, both groups, and said that in the adjacent segment degeneration rate, there is no significant difference. In the rate of pseudoarthrosis, there is no significant difference. But there is significant benefit from surgery in terms of neuric scores and neck pain. But this happens in both the groups. So they're equivocal. Their result was equivocal. The third paper, comparing 3-level ACDF with 2-level ACCF and a hybrid procedure. Again, all three techniques had similar neurologic function improvement and bone fusion rates. Corpectomy had, of course, more blood loss operation time, less cervical lordosis improvement, and mesh has a higher chances of subsidence. While ACDF had the least number of complications. Due to shorter operative time and blood loss, those complications were definitely less. Now, the hybrid has also less blood loss and operation time. There is a better segment angle improvement as compared to the corpectomy, a better C2 to C7 angle improvement as compared to the corpectomy group. So, I mean, we can keep discussing these papers. I can go through all the numbers, but it clearly says that the dyscectomy group or the hybrid group had better results than the corpectomy group. They're all coming from these papers. Now, Failings et al. Had also looked at this 2-level corpectomy as compared to 3-level ACDF. And the corpectomy group had a greater risk of major complication, longer hospital stay, less frequent discharge home, and a higher occurrence of pneumonia, DVT, or blood transfusion. While a hybrid corpectomy and when compared to a dyscectomy at 3 levels, the outcomes were the same, similar safety profile. There was slightly shorter operative duration with the hybrid procedure because 3-level disc, you need that much more time, while a corpectomy and this is probably hybrid procedure is probably shorter. While a corpectomy, the higher rate of major complication, longer hospital stay, comparatively higher risk operation. Another multivariate analysis of poor outcomes. Another paper published in 2019. Again, similar results. So we can go through the numbers. Another paper, anterior cervical discectomy and fusion versus hybrid surgery. Now, this is comparing ACDF and hybrid surgery, and it's a meta-analysis. And this says that except for blood loss and total complications, both ACDF and hybrid surgery are effective options for the treatment of multi-level cervical spondylotic myelopathy. There's nothing much to choose from between the two. I'll present a few examples. A 45-year-old male, gait imbalance, power was 4+, grip 90%, clear-cut myelopathy. This was what it showed. So it's kind of a bridging posterior OPLL. And this is what we did. We did a copectomy with a longish cage filled with bone graft and a plate on top. And it went on to fuse very well, as you see in the follow-up picture of the CT scan. Another example, a 58-year-old male, again, power, grip, imbalance, gait, and myelopathy. And here, this was the pre-op MRI and the CT scan, which showed the kind of lesion this picture shows. And here we did a hybrid procedure. We did a 1-level corpectomy, and the adjacent level, we did a discectomy with a graft. I think it's a peak cage, which we used, and a plate on top to stabilize the whole procedure. And the patient did quite well. A third case, similar things, anterior C3, C4 discectomy with C6 corpectomy with a C3 to C7. Again, a hybrid procedure. There are 2 standalone
Dr. Kale,
Yeah.
I think they have stopped the recorded video.
Hmm.
So, can you conclude if you don't mind?
Well,
To summarize, Andy.
Yeah.
yeah. So Copectomy obviously has its own complication rates. Copectomy means more blood loss, longer duration. The fusion rates are also not as good as multiple level ACDF. Now, comparing between ACDF and a hybrid procedure, not much to choose from. I mean, you can do a smaller, if it's a 3-level disease, you can do a 1-level corpectomy and then do a discectomy and then cover the whole thing with a plate on top. So, not much to choose from between the hybrid and the ACDF. But as compared to corpectomy, especially 2 levels or 3-level corpectomy, that definitely has its own set of problems. However, I must add one more thing. If the disease or if the OPLL is behind the body of the vertebra, then you have no choice. You see, you have to go through the body. You have to do a corpectomy. So it depends upon the nature of the disease. If the levels are 1 or 2 and the disease or the corpectomy is needed, then there is no choice. You have to do it. But then you have to keep in mind that these rates or these complications are higher. However, if it's more than 3 levels and the alignment of the spine is okay, I would still advise that probably it's better to go from the posterior approach, do a laminectomy or a laminoplasty or a laminectomy and fusion, and avoid long level anterior surgery for its own peculiar set of complications. That would be my summary.
Thank you very much, Dr. Kale. It was a very important tips you have given while summarizing. And any questions? I don't see any
Can I
question.
ask, sir, with your permission, can I ask one question for
Yeah,
Dr.
yeah, sure.
Sir, with your experience, in case not in these severe cases where there is more of anterior compression, if there is a degenerative multi-level spinal canal stenosis with significant myelopathy, what is your experience in posterior decompression correct the kyphosis as well?
I couldn't understand the last part. There was somebody speaking.
Yeah. So my question was, sir, in patients with multi-level cervical spondylotic myelopathy,
Yeah.
what is your experience compared to an anterior procedure, posterior procedure, where you do a decompression followed with the lateral mass fusion to correct the kyphosis as well?
Yeah. So it depends upon the degree of kyphosis. If it is only a loss of lordosis rather than a kyphosis, I would still, push the envelope and do a posterior surgery, even if I don't get too much correction. However, if the kyphosis is severe, then there is no choice. I will have to go anteriorly to reconstruct the anterior column. Otherwise, it will be very difficult to correct the kyphosis with any significant correction, so that it can affect the recovery of the patient. So straightening of the cervical spine, maybe I would push the envelope and still go from the back. But if there is significant kyphosis, then I think it is best avoided. You either do a 360-degree, you attempt anteriorly, do whatever correction you can, and then also add on the posterior so that you make sure that the spine doesn't collapse. But in a severe kyphosis, posterior surgery does not correct the kyphosis in as much as an anterior approach will. That is what I have understood over the last 15-20 years.
Thank you, sir. Thank you, sir.
Thank you, Dr. Kale.